Okay, so the oscillator. High frequency oscillatory ventilation, HFOV, is our usual acronym. This is going to be a long one. I'm sorry, but there's a lot of stuff to go over. And then there will be cards and kind of cheat sheets to like remind us what we're doing as we move forward using these more and more in the NICU. So what are our indications? When do we use them? Primarily, there's a couple other indications. Oftentimes when we have oxygenation failure, like we have known PPHN, and we have very high FiO2s, we're going to need an oscillator, often an oscillator with nitric. MEC, when we have a real MEC aspiration, these kids can get really difficult to ventilate quickly. And then the air leaks. Kids that are much smaller gestationally are more likely to blow pneumothoraxes. Excuse me. Thus, it's really important that these patients we protectively ventilate, not with the high peak pressures and the high shearing pressures that are going to destroy the lungs. So this is more of a preemptive thing. And then, of course, if they already have other issues like RDS, we're already on high settings, failure of conventional ventilation, obviously they might need to go towards the oscillator. And I will send this PowerPoint just out in a PowerPoint in case anybody wants to print any individual slides. Okay, so when do we switch? This is kind of what I was going over with the textbook one on the previous page. This is going to be basically the reasons we're going to use it. A lot of times we don't switch to high frequency on our smaller premature infants. We are going to go directly to high frequency because they have those poppable, not completely formed lungs. So if they're younger than 27 weeks, obviously needing some respiratory support, needed to be intubated in the delivery room, we're going to know that those lungs are not fully cooked. So therefore, they're going to need to be ventilated, and it's much kinder to the lungs that are going to be really poppable, really easy to destroy, for us to go ahead and start on the oscillator, because the way the oscillator works with only ventilating at a mean airway pressure, so and avoiding that open close that causes a lot of barotraumas, that causes those shearing pressures that can really injure the lungs. Our other one that you're going to see on the oscillator is that true meconium aspiration bigger kid, right? That true meconium aspiration that really is a listless meconium. It had a lot of meconium. This causes like ARDS in the lungs, and it causes areas of uneven lung disease, I like to call it, because it's like there's areas of hyperinflation where they're almost forming blebs and too much air is trapped in there, and then other areas where you cannot get the air to go. So by having this high mean airway pressure, we're using the oscillator we're using the same machine, instead of using it to protect, to be kind, we're using it as a big gun. We're using it to use that high mean airway pressure to keep those lungs open, because these RZ lungs want to close. You know, just like we saw with COVID, things like that, these lungs are just hard to keep open. They want to sit closed. So we need it's kind of like using a high PEEP, the same concept. We're just keeping them open at those high mean airway pressures. Okay, now oxygenation failure. And this is something I will show everyone how to see it, the formula in Cerner on the charting. But here is something we should always be thinking of with these babies that are on a little bit higher oxygen or are needing higher mean airway pressures on the oscillator, or even on conventional, okay, and that is the oxygen index. The oxygen index calculation should always be done on any intubated neonate, depending on if we get the different blood gas, if we different blood gas machines, sorry, then we might be able to have those automatically run on our blood gases, because what it is the FiO2 times the MAP, and like on the oscillator, the MAP is a setting. Otherwise, you would just get your MAP from your conventional, and that's divided by your PaO2. So if it's 0 to 25, that's ideal. I'm not saying there's never going to be a case where a patient is intubated and sick with a MAP of 20, 25. They may even be on an oscillator, but they may be one of our protective lung strategy oscillators, that we're just keeping them there so that we don't hurt the lungs, and they just need that support right now. Once we're at 25 to 40, those are definitely our customers on the oscillators. These babies are having oxygenation issues, and they're probably on higher MAPs, and they're needing higher oxygen. Okay, and there's some reason one of those numbers is making and they're having poor PaO2. One of those numbers is making the OI higher. If the numbers are approaching 40, that's when the team is going to start thinking about shipping them. Out because they need VA ECMO minimally. Okay, so contraindications. The only true contraindications are in the NICU are really going to be this patient is too sick to even try the oscillator, because the oscillator is using higher pressures, and so they're already getting ready to code. They're already having hemodynamic compromise. They need ECMO. We don't even need to mess around with this. If they already have known brain bleeds, already have high CPs are high, the MAP can cause issues. It's going to be a individual basis situation here. And obstructive airway disease, we would never do that, but that's something you almost never see in an infant. So, okie dokie. So, what is it doing? Here we are. The high frequency is used basically between 3 and 15 hertz. We're always going to start with 15 in the NICU, and that's basically giving us a tidal volume that's less than or equal to anatomical dead space. So this is like 1 to 3 mLs per kilo maximum. Usually it's closer to 1. And then the way it works is there's this electromagnetic diaphragm, or the piston. We'll use the word piston as we go through training and things like that, and that is generated into the circuit. The thing that makes the oscillator unique among all ventilators, and if you all remember way back in respiratory school, all exhalation is passive. We do not set anything for exhalation. Exhalation just kind of happens. Here in high frequency oscillation, exhalation is the only time it is actually an active phase. It is pulling the air out. So that's the way we are able to ventilate, even though we're using these tiny, tiny, minute tidal volumes. Okay, now they're alveolar recruitment. So these patients they're not ever going to be at full peak airway pressure like we would on a conventional ventilator. So they're never going to have that 10 rib expansion you see on a regular x-ray. So for these reasons, they can easily de-recruit. We want to never ever let them come off the oscillator once they're on until we're ready to wean it off. Okay, so that's the reason we minimize breaking the circuit and never try to take them off. Don't transport them, that sort of thing. Okay, this is a little bit of a busy slide. Let's try to go over it, how it works. There's a constant descending airway pressure, kind of like a PEEP. And that's going to be our map, which is going to keep the lungs 3/4-ish inflated, right? So the lungs are never going to deflate. And then these small tidal volumes are superimposed, per se, at the high frequency, crazy high frequency. And then there is this radial mixing where the gas mixes with laminar flow and goes down, straight down the middle. You'll see other books or textbooks how the gas is going straight down the middle of each airway, just pushing straight on through. And it's kind of like, if you think about the way vapotherm works, to even though it's just flow, but the patients can have these crazy high flows and they don't need help, exhaling. It's because the air is going straight down into the lungs, into the airways, all the way to the alveoli. And then at that same point, it's coming back out around the center on the edges of the airways. So collateral ventilation, that's just kind of when those alveoli are communicating with each other. They're next to each other, and so they're getting some, their air is going through that way. Coaxial flow, that's what I was just talking about, how going into the lungs is straight down, and then on the outside of the airway on the way up. So if you think about that, it's like the center, there's three lanes really. It's like if it's a highway with 3 lanes, but in this particular situation, it's going in down the center and on the outside of both sides of the airways, it's coming out or coming back up. Pendular ventilation, that's talking about the time constants and gas vagues. It's just another way that all these secondary ways of ventilating, it's going to push the air in because there's a constant, it's going to push the volume into the lung, even though they're minute volumes, into different areas of the lung, even though we're not using a full tidal volume, any of that. It's just because it's a constant. That's the reason that it's going to stay in there. All right, that was a lot. This is kind of looking at this one over here. We're seeing the conventional ventilation that we're used to seeing, our little shark fin, right? You're pushing air in, it's going up, and then it all comes out. In the oscillator, we're kind of staying at a mean airway pressure. We're just staying there in the middle and then just jiggling. So we're leaving those lungs mostly full, okay? And that's really how it works. Once you see it, it's a little easier to comprehend all this theory. All right, so this is what it looks like. And there's a lot of things on here, but we're going to separate it into what we actually mess with and where our set it and forget it's are, okay? So our main controls, and these are the things that we are actually going to be using. And we need to, just like with any vent setting, we need to break it down. Is it for ventilation or is it for oxygenation? How are we using it, right? So mean airway pressure is for oxygenation. Think of it as PEEP in that way only, that's going to be your oxygenation, right? So how do we set it? So say we were already on a conventional ventilator and we're going to an oscillator, we're going to go a little bit above what our mean airway pressure was on that conventional ventilator. Think about the situation where this patient is hard to ventilate, that we're having to go up and up on the settings, and we're still not getting the CO2 down or the PaO2 up. That peak pressure is already going to be set pretty high. The rate's already going to be set pretty high. Peak pressure, rate, and PEEP are what makes mean airway pressure, right? So it's already going to be set pretty high. So we're just going to go up a smidge from that in order to set up our mean airway pressure, okay? So whatever it already is on the ventilator, if it's 8, 10, 12, 15, whatever it is, we're going to go up just a smidge above it, okay? If we're going to start this premature baby on the oscillator, we're going to just choose 8 to 10 to start them with on their mean airway pressure. Baby's just been born. They've never been anywhere on any ventilators. So we're just going to choose low numbers. If they need more, we can provide more. Okay, amplitude and power. So some of you may have worked with the oscillator back in the day, and we were always talking about amp, and a lot of times they used to order the amplitude, and the amplitude is your wiggle. The amplitude is your ventilation. This is what's if your patient is not ventilating and the CO2 is still horribly high, you need to increase your amplitude. However, we do not want to actually just order amplitudes or chase amplitudes. What we want to do is choose a power to get an amplitude. And here's the reasoning why. So these are starting settings, sorry. So if it's a small baby under 2 kilos, we're going to start at 2.5 on the power. We may have to increase that if the CO2 is still high. A big thing is we need to get enough wiggle. So this is it's not much different than when you set a tidal volume. Yeah, you did some math. You probably chose 8 mLs per kilo, ideal body weight, but sometimes it's just not enough. You still cannot see that chest rise, and it's all about the chest rise. If this is no different, you have to be able to see that good chest wiggle from the nipple line to the umbilicus. Okay, you want to be able to see that wiggle. It has to be not that you could see it across the room or that you have to put your face right next to it. It has to be that Goldilocks, just perfect wiggle. And this is something that'll take a little while for you to get used to. Okay, but it's just like evaluating chest rise. Is it perfect? Okay, and when I say about we set a power and get an amplitude, for instance, let's say we set up this baby on a power of 3, and that gave us an amplitude of 28, okay? Suddenly, the next day you get to work, this power is still set at 3, but now the amplitude is 31. What should you do? And what does it mean? Well, if on the same power the amplitude goes up, that means the patient's lung are getting a little more compliant. So you may have to tweak that power down a little bit to get that same amplitude. If we're not trying to if the chest wiggle is getting a little too crazy, it means they're getting better. Okay, so we're going to wean based on them getting better. We can do a gas, we can check the TCOM, make sure it's so. But we're not going to try to keep going up and down to get that set amplitude. We're going to let the amplitude drift based on the power. Now, the same thing if you had that 25 on that 3, then and then suddenly it's only 21, that means troubleshooting is needed. Is it maybe the patient needs to be suctioned? Maybe the tube is too deep. Maybe the tube is too high. We need to troubleshoot. And if it's still, after you've troubleshot everything that it could possibly be, then the patient might be getting worse. They might need to do an x-ray. We might need to increase the power in order to get a decent chest wiggle, a decent amplitude. Okay. And it's going to depend on what the CO2 is doing, because amplitude and power, you set one, you get the other, are CO2 removal. So the higher the amplitude or power, the more CO2 should be being removed. Okay, so it's not inverse in any way. If the CO2 is high, you go up on the power. If CO2 is low, you wean it. Okay, I know that was a lot. The good part about the rest of this is it's a set it and forget it. Okay, bias flow. We usually start at 10 in the NICU. If you need a little bit more for the bigger kids, then you just add a little bit more. And what it is if you're trying to set a map of a higher map, usually 18, something like that, and it doesn't let you set it, it's because you need more flow to set that map. So that means you have to go up on your bias flow. But once you get your map set, we rarely, increase maps. We do sometimes, but you rarely have to increase them. So once it's all set, you're really going to not touch it again. Okay, hertz. This is written a little funny, sorry. So we set it at 15, which is 900 breaths per minute. We never, ever, ever change it from 15. You just leave it there forever and ever. There are a couple super rare times when we might take it down, but it's almost never done. Inspiratory time, 33%, which is our magic IE ratio of 1 to 2. Okay? We do not ever, I cannot think of a time where I did not have 33%. And this is in all ages. It's just simply not done. So even though there's a lot of knobs on there, and we'll talk about alarms in person when we're doing the labs, it's not that much. The bias flow is a set it, forget it. The hertz is a set it and forget it. And the I time is a set it and forget it. It's really only the map that you set based on your previous conventional ventilation and or based on gestational age. And then, of course, your power, again, based on that chart on this one. Okay. When do we wean? When can we come down? Okay, so 16, 17, less than that is pretty good. Mean airway pressures are pretty good because this is a little bit higher. And there's going to be times when, just like we keep the babies on bubble CPAP forever until they're 32 weeks, when they're really, really small, we're not going to wean them even if everything's really good. If the FiO2 could be room air, we're going to wean the FiO2 as much as possible, just like we do on conventional ventilators. Power less than 4 is always good. And then again, when we go back, we're going to use a map of a little bit less than the map we're using on the high flow. And then oftentimes, especially when these ones that we're not using this because we couldn't ventilate or they were meconium aspiration or something crazy, but if we're doing it as a protective lung strategy, they'll extubate and just put them on CPAP when they get a little bigger, when it's safe to do so. So this is the part that makes everybody crazy, is because this is such a great machine and it's a crazy machine and it does a lot for the patient, but sometimes it takes a minute for it to work. So in that first 30 to 60 minutes, the SATs can change dramatically. There are times when the SATs will go down before they go up, and we have to go up on the oxygen before we can start weaning it, because we're doing a different kind of ventilation here and we're only inflating to that mean airway pressure, whereas when we were bagging and doing all of that, it was a little different. Okay, so we want to give it like that hour, maybe a half an hour, maybe 45 minutes if it's working for that X-ray and gas. Okay, we need to be really good at judging that jiggling, wobbling chest wiggle. If they're wobbling, if they are jiggling, and if it looks good, they are ventilating. Okay, the X-ray, when we do the X-ray, we need to make sure we're counting our ribs and making sure it's 8. It can be slightly less than 8, but we don't want it to be more than 8, because if it's more than 8, it's going to be the patient's hyperinflated, and that means our MAP is too high, and that will impede our ventilation. We want to use the TCOMs with these. We want to be monitoring. Of course, we'll get blood gases as well, and most of these patients, of course, will have UACs, we would hope. And then just remember that lung compliance can change. You know, if we if there is something going on with secretions, something, maybe it's meconium aspiration, there's something, the tube can get blocked. We really want to be aware of that. There's a lot of times where we really have to adjust the tube often in these patients. I don't mean adjust it as far as putting it in and out, like retaping it, any of that. It's just sometimes because they're so small and that increases the resistance so much, the ET tubes are so small, that increases the resistance so much that the angle is very important, that they're not doing any kind of weird angles, that it's a nice mellow arch, that we trim our ET tubes. Okay. Always closed suction. Always two-person cares. The nurse shouldn't even be changing a diaper without the respiratory therapist at the bedside, because anything can happen. We really want to not let that patient become off the oscillator for any reason. Okay, this is the TCOM. We'll have a whole in-service on our TCOM, but basically we're just going to be monitoring through the skin our CO2 and hopefully PaO2. Usually the newer ones have both available. And this is Centec, the picture in on the slide, so hopefully that's the one we get. Okay, quick troubleshooting guide. There are much more complicated charts coming. I will again send these out via email, and everybody can feel free to download what they would like to have as a reference. So oxygenation, obviously FiO2, and MAP. MAP is oxygenation. Over oxygenation, if they're 2 and 2, well, we can decrease the FiO2, especially if we've already confirmed with an X-ray that we're at the sweet spot with our MAP. Going down by 1 really doesn't de-recruit too much. Going down by 2, they would have had to been on the overinflated side on the X-ray. Ventilation, increase the amplitude, but which we do by the power, okay? And then again, decrease the amplitude. The frequency in the hertz is what makes everybody crazy, because it's inverse and it's hard to understand. Know that it's almost never done. That's why I'm kind of skipping over it. I'll show it to you on one slide, but it's just a lot. Okay, so we said that we start with a 15 of hertz, right? And that's what we always start with in the NICU. This is doing a crazy decrease just to show you, for an example, just how much the tidal volume increases. So if you go from a 15 of hertz to a 6 of hertz, your tidal volume goes up by 3. And that's why decreasing the hertz increases the tidal volume. Having said that, it's almost never done unless we're really in a really bad place, and it's always going to be with a bigger kid, like a meconium aspiration kid. This is that really busy detailed chart I told you. I can always send it to you, but we're not going to go over this. Nitric. Nitric is very, very often used with the oscillator. It's usually our PPHN kids that are a little bit bigger, that are a little bit artsy, they're stiffer lungs, they need that high pressure or the constant pressure, and along with the nitric oxide to compensate for that pulmonary hypertension and to decrease the pulmonary vascular resistance. Okay, that's what nitric oxide does. Okay, this is a lot. When in doubt, ask. Ask for help. We are going to have lab after lab after lab. There's going to be resources. There's going to be quick references, guides, and just ask for a second opinion. It is not crazy. It's not weird. This is a totally different way to ventilate than anything else that is used. Okay, it's like we're talking hertz and amps, which are things, unless you're an electrician, we don't usually talk about. Okay, so we will always, always, always support, anybody's questions. All right, so quick little summary. It can be very lung protective, and that's why we're going to use it on our littles. You know, the tidal volume cannot really be measured. Wiggling is super important. If it's not wiggling, it's not working. MAP is oxygenation. Okay. Higher power is, and a delta P is more ventilation. Okay. And this is what I was talking about, as amp increases on the same power, the lungs are improving. Reverse is true as well. And then again, try not to even worry about the I time frequency or Byers flow. And then transporting, this is where it gets crazy. Luckily, we're not that kind of hospital where we have a lot of specials that our babies need to go to. But yeah, it's very, very hard to translate on an oscillator. It really cannot be done. These oscillators do not, there's no transport version. Okay, and so that's going to be the big thing. So that's why we really want to make sure we're doing the OIs, especially initially, because if that OI is already starting to get to ECMO level, it might as well be, we should put them on maybe nitric and a conventional ventilator and ship, because they need to get cannulated and get on ECMO right away. These are some references. They should be clickable. And so I will send the whole PowerPoints out via email, okay? Because this is there's a couple pocket guides here that give you a lot of information. Okay, thank you.